thank you for still bearing with us. So in continuum to the tricuspid session in the morning, we didn't give some of the treatments. It's يعني حقها. So we're gonna go and talk about the trick valve. The Bicaval is like the new therapy. We have heard a lot, it's a palliative treatment, but is it really a palliative treatment? Or maybe it's something, a last resort for our patients. So, 74 years old lady, multiple medical problem, as usual, atrial fibrillation on anticoagulation and pacemaker lead. She's been having right-sided heart failure. Her left side is doing relatively normal or acceptable EF, but some mild or moderate MR, but significantly severe tricuspid regurgitation with an acceptable PA pressure of 50. I'm not gonna go through the images because you can just imagine this, the same images of the morning. But I will go for the classification. As now, it's not just a simple primary, secondary TR. We have to look at it in a more perspective, a more broader thinking. This is a SID, or what we call cardiac implantable electrical device-related TR, and that's make it more challenging to treat. And unfortunately, our guidelines are still not catching up to have the best solution, with the exception of maybe in a shy introduction or honorable mention in terms of going for percutaneous option in highly volume center. We've seen these images again and again and again. We talked this morning about all these kind of therapies, but sometimes when all fail, you have to have something to back up and stand on it, which is the Bicaval approach. So going back to our patient, I will just go for the point values, which is like, that it's a CT measured case in order to get your measurement to know the sizes. But now we have introduced some MRI. Not every center can do it, and now we can listen that some people are doing it with IVUS or an ultrasound to have the measurement. But you have to have the volume up before you do that. So our patient was suitable to go with a 25 size and the IVC with the 31 size. You always aim for some oversizing of 20 to 30% to make sure that the valve will stick. And the most important, the first one, which is the superior vena cava, is not a big deal, but it's the inferior vena cava which have the tendency to move up and down, and you have to have a good atrial caval distance. Once you have a shorter one or a bit bent, then you might have encounter some difficulty. Just going through over of the valve itself, we have the superior vena cava one with the belly, and then you have also the one in the inferior vena cava. You can see that this is where you have the strength and nitton, and this is where you have your valve. This is the crown, the belly, and this is your valve here. And whereas in the IVC, you have your leaflet here, which is about short skirt. It's a 20 millimeter. And you can see there is a translucent line here as we go forward. So this is to understand only the sizes. The one in red is the one that's available so far. They're working on the upper one, and hopefully shortly we'll get them, because as we know, those patients have bigger anatomy than our expectation. To have an overflow and putting the anatomy all together, this is more of a 90% guided fluoroscopy, which makes us, the interventionists, extremely happy. But you can have a PA catheter to guide you when you implant in your first few cases to implant the superior vena cava. Nevertheless, the TE may help you in the inferior vena cava in the upcoming first cases. So this is what you aim for. You want your crown to be here, the belly to be above the PA catheter, and your leaflet will be around here. This is your jugular vein. You put like Landerquist wire, and this is your subclavian, and this is your innominate. Why do we say above as much as possible? Because you do not want to occlude the innominate. And this is where, as we saw in the first few pictures, where is your leaflet, where is your skirt? So that's why you don't want to occlude this. You might occlude the azygos vein, but it's not a big deal, and it has not been reported to be a big issue. So in the first few cases, you can put a PA catheter, and that's your aim. So back to our case. Like I say, like a picture is worth 1,000 words, because always a question, is it okay to put it with a pacemaker or a lead? Well, there you go. You can do that. And actually, we brought our AP technician pre and post the case and see the response of the device. And it was not a big deal. You can see there is an oxygen mask, and there's a PA catheter, but there's no TE probe. We felt comfortable at this stage that maybe we'll be fine without an intubation in this case. We have done a couple of cases before, so this was not our first radio. But I wanted to be confirming and put the PA catheter to be 100%, and our position was very nice. You can see we have almost like secured the pacemaker lead, but it wasn't an issue in this case. Moving on, this is the most difficult part, which is the IVC. When we looked into it, this is what you aim for. But sometimes when you have some bend or tortuosity, you might consider going to a lateral or another view to open this angle here. So that's what you should be seeing. Sometimes it may be deceptive that you are low or high, but actually it's just go to another view. So this is another view, like having all together, like having a visual impression about where should your valve be, where it should be, how much of protrusion, because we have some imagers in the room, that's what they should be seeing. Back to our case. You can see the transition here. There is like this is like some of like what will happen now in the case. We have a double vision here. We were thinking, and this is basically where is your skirt. We felt that we were too low. We should go up a bit. But still, because you can have half of it, because in this case, the injunction was a bit short. We felt still, and we didn't have a TEE, and the transthoracic wasn't much helping, and the patient was taking deep breath. This wasn't good, so we recaptured again. And then we positioned, and we felt, you know what, this looks good. I mean, even if you have some of the skirt here, but it will be fine. Unfortunately, as we were deploying, unusual to the valve positioning, usually it pops up, it popped down. Okay, so there was lots of technical issues going on in the background, a possible sizing situation and the volume of the patient when the CT was done. Just to keep in mind, if your CT is like 6 months before and it was like now 7 or 8 months for doing the procedure, you have to repeat the CT because the volume status of the patient may be different. So we went down. You can see we are down here. And we did the transthoracic on the table, and you can see there is a significant paravalvular leak here. We were not happy, of course, despite the protrusion was reasonable, but it kept going down. The valve kept going down. So the paravalve started becoming more and more increasing. So the decision was just put another valve and make it, for whatever reason, from the technicality, we can go through it later on, we put a second valve. And though it looks here lowish, but it looks very nice. We have this now here. We have some protrusion. We have an excellent hemodynamic response with the RA was, the V wave was 70, and we went into the IVC 36. So despite we have some protrusion, and despite that my imager was very upset with me. He said, if only you let us do the TEE from the beginning, we wouldn't have went through this. But we had our own technical issue from our side. This is our transthoracic next day. Looks amazing. Even this is like an offside note. You can see the TR signal lessen after the bicaval implantation, and even the width of the Doppler. So you can keep inside, and even the gap sometimes it starts to get lesser. But this is the first day, so you cannot be 100% sure. We saw her in the beginning of May of this year. Patient is completely asymptomatic, and because of the patient is asymptomatic, she started to go down with her medication, and she's actually started to have high blood pressure, so we just amended her blood pressure medications. So this slide has been presented in EuroPCR like 1 month ago or less than 1 month ago, which is the registry including 204 patients, because the question is always, you're saying it's palliative, it's palliative. We have few cases here and there, but what is actually happening across the world? So these are like thankful to the people from the trick valve, they supplied me with this. You can see what this is your criteria to include which patient in terms of who you should reject. So don't take patients with bad RV, they will fail. Don't take patients who do not move, they will fail. Don't take patients with high PA pressure, they will fail. Or don't take patients with bad LV to start with, because they will fail you. And you can see the baseline characteristic. We have good number who had surgeries, 30% almost who had the previous tier or even annuloplasty, and there was like also 30% who had leads. Not only that, there were almost 60% has hospitalization, and most of them have massive differential TR. And this is what I say again, look at the classification of TR from another point of view. And as we see, the success was extremely high. I mean, but they had, again, like I had, some migration and implantation of a second device, and there were some mortality because those patients, it's extremely high-risk patients. They are not simple patients, because my belief, TR is not a valvular lesion or valvular disease. It's a systemic disease. It will affect your liver, your kidney, your hemodynamics, and your blood. And by the time it comes to you, the patient is already on his end of it. And of course, because those patients require anticoagulation lifelong, you have to consider the bleeding risk. Okay, so they did very well, those patients, okay, as we said here, and complication basically as a procedure failure or whatever, it wasn't that bad. And in hospital mortality, we went through it already, malposition and whatever, we went through it. There are some leak case, residual leak, which is, I just showed you in my case, okay, and the bleeding, which is not, you know, it's expected. They had one case of a stroke. There are valvular thrombosis, which was in the suprahepatic vein, and one pacemaker dysfunction and requiring of implantation. But aware your patient that next day you have a 50 to 70% chance you might have a shoulder pain. In the beginning, I used to give them gabapentin, but now I defer this because those patients are elderly with multi-medical problem. They might go off on you in the next day. So maybe ride the pain, give them some non-steroidal, 3-5 days, and it will go away. We have seen dramatic improvement in the functional capacity and the walk test and the quality of life. And even the diuretic dose, like Dr. Salim Asiri showed us in this morning, his case, the patient went to 20 milligram Lasix. And the results like mimicking life. This is the expectancy. They will have better life quality, no more ascites. You can see it. It's like almost like your p-value is 0.001. No more peripheral edema, because this is the first thing that they will tell you the next day. I don't see my peripheral edema. I just have the shoulder pain. And then you have also dramatic improvement of the symptoms and the weight loss. There's a reduction in all of these, as we mentioned. But the people who had been admitted because they have lots of comorbidities, so keep that in mind only. That's why pick a good candidate from the start. You might find a dip in the right side. That's why you have to have a good TAPS. You have to have a good right and a good left system to pull you up, because your left will help the right. But after there's some papers coming up that within 6 months, they might have a remodeling. And the hemodynamics, this is like why I showed you our V wave dropping from the RA to the IVC, because it's a prognostic element. Once you see that, your patient is going to do well after that. And this is further events, just for interest, because for people, some patient has some bleeding and intracranial hemorrhage, and some people end up with dialysis, just to keep that in mind, which is not still something that we prefer to have a permicath or a dialysis going through the valve, but it happens. So, if you had it, it could happen. And one case has been documented for infective endocarditis, which was treated medically. And there's a couple of cases with pericardial effusion. One of them was later, after 1 year, possible from irritation of the RA or related to anything because of the anticoagulation. We can say the heart failure hospitalization of the trach valve has improved dramatically. And you can see the predictor of mortality or heart failure hospitalization after the trach valve. So if you can see, if you have multiple medical problem or kidneys in specific, your risk will go high up again. And I'm concluding within 15 minutes based on the people who asked me to conclude my talk. I will just give you the conclusion. Cavity trach valve is feasible and safe. It's easy. It's not difficult at all. It's a self-expandable valve, dry seal. You just take it out of the shelf. It doesn't need a prepping. It just need a flush. You just need a couple of axes, one in the left, which is going to be your pigtail, and one in the right, which is your axis side. 27 French, 2 Proglide, or figure of 8, whatever you're comfortable with. And then you just go to the jugular, implant the first one as high as possible. Make sure that you don't occlude the innominate. And then you go to the IVC. In the beginning, I advise to be under GA with the control setting with the support of the TEE, and then deploy your inferior vena cava, slow deployment. And then do your hemodynamic, and the case is concluded, and the patient can be discharged within the next day. Expect some shoulder pain. Patient will, you can manage it, as I mentioned, either with gabapentin, though I'm differing from elderly people, or non-steroidal. And finally, you can check them within 6 months to 10 months. Maybe they will have some remodeling. Okay, it's compatible. No problem with having a PPM or an ICD lead. And they need lifelong anticoagulation. Luckily, 90% of these patients are already on pre-existing anticoagulation, Coumadin, warfarin, NOAC. But if they're not, the choice is yours. There's no something written in stone that has to go with this or that. Readmission will decrease. acidic type will decrease, peripheral congestion will increase, and the functional capacity will improve, and most importantly, the quality of life will improve. And with that, I conclude my case. Thank you for listening.